Hello and welcome everyone to this session on case-based scenarios in medicine part 11. My name is Dr. Jhanvi. I am the anesthesia educator on Unacademy, and today we are going to be discussing a lot of anesthesia related case-based scenarios as well as surgery related image-based questions in this class. So before we begin, I hope that all of you all are able to see me and hear me well. You can leave a thumbs up in the chat box if the streaming is okay. Yes, I can see that the streaming is absolutely fine. Alright, so we can begin with the class for today. You guys can message me on the chat box and I'll be able to see your messages over here. This is going to be an interactive class, and so I am a gold medalist in anesthesiology, and this is the Telegram channel Let's Crack NEET PG, where we get the links to all the free classes that we take. So we are taking free classes for you guys on YouTube. We are also taking free classes for you guys on the special class platform. So all of these are available for your NEET PG preparation, and along with that you also get the plus classes in which we take our individual subjects. These are our FMG December 2021 toppers, and the plus subscription on Unacademy will help you get access to live and recorded classes. You can learn from India's top educators, you can compete in live tests and quizzes, you can study on the device of your choice and access our question bank with 25,000 plus questions. The iconic subscription is a partnership between Unacademy and PrepLadder, which will help you get the live classes of Unacademy along with the video lectures of PrepLadder. We have the NEET PG All India mock test. This is on the 26th of February at 9 AM, and here you guys can try to see what is your ranking amongst your peers. You can also get a whole new question bank of questions which will be helpful for the preparation of your NEET PG exam. We also have the educator curated test series, which are for individual tests like for medicine, orthopedics, gynac, surgery, biochemistry. We had the anesthesia test on 18th. I hope you guys attempted it. Then in our special classes, which are available free for all of y'all, you will get interactive live classes, polls for the learners, raise a hand option, and also lecture notes at the end of it in the form of a PDF. These are the plus batches that we have going on right now. The NEET PG 2022 all educator revision batch, and the target next 2023 subject wise batch. So I am going to be starting this batch on the 24th, that is on Thursday. So I hope to see all of you all in this batch. The Focus FMG comprehensive and December batch is also coming up, and along with that, if you guys would like to attend any or all of these batches, you can buy a single plus subscription and use my code Dr.Jhanvi Live, with which you get an extra discount on your plus subscription. Alright, so with that, let's begin with our first question for today. A 40-year-old female on tablet fluoxetine for depression for the past 4 months is posted for elective cholecystectomy. As an intern, your advice regarding the use of fluoxetine is what? A. Withhold fluoxetine for 2 weeks prior to surgery. B. Withhold fluoxetine for 2 days prior to surgery. C. Withhold fluoxetine and replace with MAO inhibitors. Or D. Continue fluoxetine. So what is your advice regarding antidepressants in peri-op anesthesia? In perioperative care or in anesthesia, what is your advice regarding antidepressants? Okay, so remember, we are talking about, whenever we are talking about antidepressants, antipsychotics and drugs for mania, okay, or bipolar disorder, all of these agents need to be continued on day of surgery. Why? Remember, these patients should not have episodic attacks of the psychiatric disorder that they have. How do you prevent the episodic attacks? If you are maintaining correct drug levels, therapeutic drug levels in their body, they are not going to have episodes of mania, depression, psychosis, all of those. Alright. So if on the day of surgery you end up skipping the dose, saying that no, patient is fasting, we should not be giving patient the dose. And the second thing is, other than skipping the dose, if you also end up having put some stressful factor into the patient's life, like undergoing a surgery. Of course it will induce some kind of anxiety in the patient, or the patient will be very reluctant to go in for surgery. So as a result of this, you are doing two things. You are adding a stressful situation, and you are skipping the dose of the drug, therapeutic dose of the drug, so that reduces the therapeutic levels in the body of the drug. So this can lead to exacerbation of the condition. Alright, so rest assured, this patient is going to end up having some kind of attack, either of mania or bipolar disorder or depression or anxiety, whatever the patient is suffering from. Okay, so ideally, if they ask you in the exam, what do we do with antipsychotic agents, remember that you are supposed to continue all the antipsychotic agents perioperatively. So on the day of surgery, the patient should continue fluoxetine. Now there is only one agent that you should not continue, and that is lithium. Remember, lithium should be stopped 48 hours prior to surgery. Lithium is used for treatment of mania. Why do we stop lithium 48 hours prior to surgery? Because lithium is responsible for interfering with the metabolism of the anesthetic agents. So as a result of this, it acts on the liver and it increases the metabolic time. It causes delayed metabolism of your anesthetic agents, and that is why there could be delayed recovery from anesthesia. Okay, so to avoid that, lithium should be stopped 48 hours prior to surgery. The rest of the drugs that are there, they should all be continued in the patients. All right. Okay, now with that, let's discuss a few other agents that they constantly ask in the exam. So while you guys answer this question, I will tell you about the other agents also. So for a case with major blood loss, the anesthetist wants to insert an arterial line. Which among the following is the ideal artery for invasive blood pressure measurement? Ulnar, radial, brachial or femoral? Alright, so what is the answer to this, guys? If you want to use an artery for invasive blood pressure monitoring, you know, we say arterial line monitoring. If you want to use an artery for arterial line monitoring, what is the answer for it? Okay, Manoj is saying radial artery. Any other answers? Alright, so radial artery is absolutely correct. Okay, why do we prefer radial artery intraoperatively? Okay, intraoperatively for invasive blood pressure measurement, we prefer radial artery. Why? First of all, it is very superficial, it is easily palpable, so as a result of this, you can easily feel the artery and you can insert the line. Okay. Second of all, if the radial artery, because of continuous pricking, you're trying to take the radial arterial line but you're unable to take, so you keep pricking. If the artery goes into vasospasm, then at least you have a collateral artery, that is the ulnar artery, which can supply blood flow to the hand. Okay, so as a result of this, we do one test which is very important. This is called as Allen's test. This is done before we take the radial arterial line to check the patency of the ulnar artery. So suppose the radial artery, there is some thrombosis or there is some vasospasm and it cannot supply any blood to the hand anymore. So what you do is you make sure that the ulnar artery is supplying blood over here. Okay, so it is patent to supply circulation to the hand, collateral circulation to the hand. The next thing which is good with the radial artery is, other than superficial and other than having a collateral circulation, usually during the surgery the hands are out like that. Okay, so if ever your radial arterial line is not reading correctly and you want to manipulate the line a little bit, the hands will be out like this. You will not be very close to the surgeon, so you can easily manipulate the line. Alright, so and it also gives a very good trace, so you don't need to put a central arterial line every time like femoral. The problem with femoral line is that it is close to the groin, so there can be a lot of infections. The problem with ulnar artery is that it is little deeper as compared to radial artery, so it's not that easy to palpate, and it's also smaller as compared to radial artery. The problem with brachial artery is that if you puncture the brachial artery again and cause a thrombus, you can cause ischemia of the hand. Alright, so that is why the most preferred arterial line for invasive blood pressure measurement is radial artery. Alright, so continuation of the previous question. Which antihypertensive agents will you continue? Which antihypertensive agents will you omit on the day of surgery? Which antihypertensive agents will you continue? Which antihypertensive agents will you omit on the day of surgery? Any idea? Pre-op medication orders. Chalo batao. Alright, so guys, remember, all antihypertensive agents can be continued on the day of surgery except two agents. And what are these two agents? Except ACE inhibitors and angiotensin receptor blockers. Okay, these are the two agents that cannot be continued. So except ACE inhibitors and angiotensin receptor blockers, you can continue all the agents. Okay, now with OHAs and insulin, patient is fasting on the day of surgery. If you give them OHAs or insulin, that will further lead to hypoglycemia. So you will omit all hypoglycemic agents. Omit all hypoglycemic agents. Okay. Now, thyroid medications. If the patient is on thyroid medications, anti-thyroid or pro-thyroid, okay, any of them. If the patient is on thyroxine supplements or if he is on anti-thyroid medications for hyperthyroidism, you have to continue all of them on day of surgery. Okay, and last but not the least, if they want to ask you some difficult questions, they will ask you about the blood thinners. Okay, so patients who are on blood thinners, so there are 3 blood thinners that you should definitely know and when to stop them. So remember, aspirin can be continued on day of surgery. Second is clopidogrel. Clopidogrel needs to be stopped 7 days prior to surgery. And the last one is warfarin. Okay, so warfarin needs to be stopped 5 days prior to surgery. These are the ones that they keep asking again and again, and these are the ones where people make the maximum mistakes in. That's why I'm revising this for you guys. Alright, so you should be able to answer these. These are basic questions from anesthesia that can come in your exam. Okay, moving on to the next question. For a EDH, extradural hematoma evacuation case, the anesthetist chooses to induce the case with thiopentone. Thiopentone has a rapid onset of action because of rapid redistribution, high amount of unionized fraction, or low lipid solubility. So this is one of the topics that I always tell people, very important in anesthesia. The drugs in anesthesia, what is their mechanism of action, where are they preferred, where are they contraindicated, all of them. So what is the answer to this, guys? Okay, first of all, can you tell me why is the anesthetist preferring thiopentone in this condition? At least that much. EDH evacuation case. So what is the problem over here? There is raised ICP. If there is raised ICP, what can you get? You can get seizures, correct? So what is the good thing about thiopentone? Thiopentone reduces the intracranial pressure. That is the one thing that it does. And the second thing that it does is it is anti-epileptic in nature. Okay, so because it is anti-epileptic, this is why we prefer to give thiopentone for any kind of neurosurgeries. So this is a neurosurgery, so we'll prefer thiopentone. Now, they are not asking you why you prefer thiopentone in neuroanesthesia. They are asking you why does thiopentone have a rapid onset of action. Okay, so Manoj is saying answer is rapid redistribution, but that is not the answer. I agree with you that thiopentone has rapid redistribution, but that is the reason for its short duration of action. Short duration of action. Now, why does it act quickly is because it has high amount of unionized fraction. Okay, now what do you mean by high amount of unionized fraction? So let me show you guys what it means. So Suppose this is your nerve, okay, and around the nerve you have this layer of lipid. Around the nerve there is this layer of lipid, okay. Now to act, your thiopenton has to cross this layer of lipid membrane and it has to enter inside and it has to attach to the sodium channel, correct? Your thiopenton has to attach to the sodium channel. Now to cross this lipid membrane, there has to be a very important chemical property of thiopenton, and that is it has to be in the unionized form. So remember, whenever the drug is in the unionized form, it has high lipid solubility, okay. So the more the unionized form, the more faster it will be able to enter inside the nerve and act on the blockage of the sodium channel. So if it has a high amount of unionized fraction, it has higher lipid solubility and it has faster onset of action, okay. Higher amount of ionized fraction, it will have lesser lipid solubility and it will take time to act. So the reason that thiopenton has rapid onset of action is because of high amount of unionized fraction, okay. Now what is the importance of rapid redistribution of thiopenton? Rapid redistribution of thiopenton means the action site of thiopenton is on the brain. It has to act on the brain, it has to reduce the activity of the reticular activating system, and it has to put the patient off to sleep, correct? So once it reaches the brain, within 5 minutes from the brain, it goes to other parts of the body. It goes to the muscle, it goes to the fat, it goes to every part of the skin. So as a result of this, the drug is now going from the target area to the non-target areas. So non-target areas may anyways it has no work, correct? So once it leaves the target area, the action of thiopenton will be over. So that is called as rapid redistribution. So it is getting redistributed to muscle, bone, fat, all these places, and the action on the brain is going away, on the target site is going away. So that is why it is said that thiopenton has a short duration of action, because of rapid redistribution. Alright, okay, got it? Okay. Next question. A known case of hypertension which is well controlled on tablet captopril for the past 2 years is posted for elective cholecystectomy. He is placed under ASA 1, 2, 3 or 4. Chalo batao, this is the easiest question that you guys could get. Okay. Trilok is saying ASA 2, Manoj is also saying the same. Guys, so many of you are online but you all are not replying in the messages. Yes, good Nimesh. Please do reply, because this is the place where no one will judge you for giving the wrong answer. But if you make mistakes in the exam, then that will be a problem. Alright. Okay, so absolutely correct. So he is having hypertension and he is taking treatment for it, and hypertension is well controlled, okay. So this is ASA 2. Now I'll give you a similar situation. So this patient is coming to me, I check his BP, he says I'm on tablet captopril and his BP is 180 by 100 mm Hg, okay. But along with that, he is saying that he has also started getting proteinuria now, and he is also having hypertensive retinopathy. So now can you tell me what is the ASA classification of this patient? He is having proteinuria, that means his kidney is also getting involved because of hypertension, and he is having hypertensive retinopathy. So now what is the ASA classification of this patient? Any idea, anyone? No, Manoj, it is not ASA 3. Trilok, very good. So this would be ASA 4. Okay. Now, how to identify between ASA 3 and ASA 4 and ASA 2? Okay. So ASA 2 is basically a person who has a well controlled systemic disease. Okay. He is on treatment and he has a well controlled systemic disease. Now, ASA 3 and 4 may there is a very small difference. ASA 3 will have uncontrolled systemic disease. ASA 4 will have uncontrolled systemic disease, plus there is some multi-organ involvement. Okay, so when I say multi-organ involvement, what do I mean by this? I mean that there is end organ damage. In ASA 3 there is no end organ damage. this end organ damage is absent, okay, but in ASA4 you will have end organ damage. So here what are we getting over here? We are getting a patient who has uncontrolled BP plus his kidney is getting damaged plus his eye is getting damaged because of the hypertension. So this is someone with end organ damage plus uncontrolled BP. So he falls in ASA classification 2. Alright. This guy will fall in ASA classification 4. Only if he had uncontrolled BP, that would be ASA 3. And this guy which we have in the question, he has well controlled. So he is ASA classification 2. Okay. What is ASA classification 5 and ASA 6? Anyone? 6 तो easy है. ऐसे 6 लिखा ना, उसका उल्टा लिख दो. 6 का ऐसे उल्टा लिख दो. This is the mirror image of 6 and then you can just think that he is dead. Okay, so this is someone who is brain dead, that is ASA status 6, and ASA status 5 is someone who is almost dead. Okay, so this is a moribund patient on whom if you don't operate then he will die. So 6 is dead, brain dead for organ donation, and 5 is someone who is almost dead. And then the only one that you have left is ASA status 1. ASA status 1 is someone with no comorbidities, not pregnant, not a smoker, alcoholic, none of them. Alright, so that is our easy way of remembering ASA classification. Okay? Okay, next one. During the maternal mortality meeting of a tertiary care hospital, they are doing an audit on the maternal deaths. Most common cause of maternal mortality following general anesthesia is hypotension, arrhythmias, pulmonary aspiration or amniotic fluid embolism. Okay, so Trilok is saying A. Any other answers? Balu is also saying A. Okay, so tell me, usually maternal mortality following general anesthesia. So usually most of the babies are born without anesthesia, correct? Because they are born by normal delivery. Now those requiring LSCS, you have two options. In LSCS, either you can carry it out under spinal anesthesia or you can carry it out under general anesthesia. Barabar? Am I right about this? Either under spinal or under general anesthesia. So now if I am going to carry this out under, in 90% of the cases, LSCS is carried out under spinal anesthesia. But in 10% of the cases where there is an emergency, there isn't time to give spinal to the patient, or if the patient is having other comorbidities like she has had seizures or eclampsia, okay, so in that case I have to give GA. Now what is the problem with giving GA to a pregnant patient? So there are many things. First of all, they are obese because they put on weight during pregnancy, so that makes the intubation difficult in them. Second thing is they have vasodilation everywhere because of progesterone, so that is why there is a lot of edema of the vocal cords, and that makes intubation difficult in them. Third thing that is problematic is because of the uterus pressing on the diaphragm, they have reduced functional residual capacity of the lungs. So the amount of oxygen that is present in them is less. So that is why they can tolerate hypoxia for less. So the time for intubation that you have is less. Okay. The fourth thing is because of the gravid uterus pressing on the stomach, they have increased chances of aspiration or increased risk of aspiration. Okay, so that is why GA becomes very scary in a pregnant woman. Okay, now I have to intubate this pregnant woman. So during intubation, the most common thing that can happen is pulmonary aspiration of gastric contents. Okay, so because of progesterone, the food does not move ahead, so there is always some amount of residual food that remains in the stomach. And the second thing that happens because of the gravid uterus is that there is pressure on the stomach, so there can be easy aspiration of gastric contents. Okay, so that is why I want to avoid all this pulmonary aspiration of gastric contents, and this is the most common cause of maternal mortality following general anesthesia. Alright? Okay. Next one. In a case where nitrous oxide and oxygen are being used as carrier gases, the patient starts desaturating during closure of the wound. Diffusion hypoxia is observed in anesthesia during induction with halothane, induction with nitrous oxide, recovery from halothane or recovery from nitrous oxide. Trilocyan, it is following general anesthesia, correct. So induction of anesthesia is a part of general anesthesia, correct? Like intubation is a part of general anesthesia, that's why. Alright, so what is the answer to this? Nitrous oxide and air are being used as carrier gases. Patient starts desaturating during closure of the wound. Diffusion hypoxia is observed in anesthesia during okay. Alright, so what is diffusion hypoxia and with what is it seen? Alright, so diffusion hypoxia is a condition that is seen whenever we use nitrous oxide as a carrier gas. Okay, now remember, nitrous oxide that is there, it is highly lipid soluble, so it crosses all the membranes of the body very easily. Okay, so this is your lungs, these are your blood vessels, pulmonary blood vessels, this is my heart. From my heart my aorta is going, and here I will draw the brain. Okay, now whenever I switch off nitrous oxide, okay, so whenever I am using nitrous oxide, initially it will reach the brain, and once the nitrous oxide is switched off at the end of surgery, I want to wake the patient up. So when I switch off the nitrous oxide, it will quickly go from the brain back to the blood vessels. It will go through the venous system, not through the aorta. We just imagine it's going back to the heart, and from the heart it is going back to the lungs, and it is suddenly filling the entire lungs. Okay, now what has happened is nitrous oxide is highly lipid soluble, so it's filling the lungs fully. So the amount of oxygen that I had in the lungs is getting diluted over here because my lungs are now full of nitrous oxide. So this condition is called as nothing but dilutional hypoxia. Okay, so the nitrous oxide is diluting the entire oxygen that is present in the lungs, and that is why I am having dilutional hypoxia. Okay, so this is called as diffusion hypoxia or dilutional hypoxia. How do I combat this condition? Before I switch off the nitrous oxide, okay, what I do is that I increase my oxygen flows so that my lungs are full of oxygen. So by the time nitrous oxide comes back to the lungs, there is enough amount of oxygen so that there is no dilution. Okay, so this happens during recovery from nitrous oxide when you switch off the nitrous oxide at the end of surgery. That's why they are saying over here that during closure of the wound means surgery is ending. Okay, and patient starts desaturating. This is because of dilution of oxygen in the lungs. Okay, so this is dilutional hypoxia or diffusion hypoxia. Okay, moving on to our next question. A patient is getting operated for a maxillofacial surgery, and the plan is to put endotracheal tube through the nose. Indications for the use of nasotracheal intubation are all except awake intubation, oral cavity tumor, fracture of the mandible or fracture base of skull. Okay. So Manoj is saying base of skull, Trilok, Nan-PK all saying fracture base of skull. That is absolutely correct. Okay. So patient is getting operated for maxillofacial surgery and you want to put a endotracheal tube through the nose. Okay. So this is nothing but nasotracheal intubation. Now when do you do nasotracheal intubation? I put the tube through the nose whenever I have surgery of the maxilla or if I have surgery of the mandible. Okay. So what I want to do is if I put the tube through the mouth, I am operating over here, so the tube will keep coming in the middle of the surgeon's field, so the surgeon can even cut through the tube by mistake. Okay, so to avoid that, what I do is put it away from the surgeon's field, so I put it inside the nose. When I put the tube inside the nose, what happens is that the surgeon can easily operate on these areas without being worried about the tube. Okay, now if I put the tube for a fracture base of the skull, so fracture base of the skull is nothing but my cribriform plate is fractured, correct? So if for fracture base of skull, I put the tube through the nose. So what is the problem with that? The problem with that is that when I put the tube inside, it can actually go through the fractured cribriform plate and it can enter into the cranial cavity. The second thing that can happen, suppose it goes down only, it goes into the trachea. So even if I am doing a nasotracheal intubation, because there is a direct connection between cranial cavity and the nasal cavity, this patient is going to have CSF rhinorrhea. This is a foreign body that I have. That foreign body is going to harbor a lot of bacteria in it, and because of the bacteria that are present in the foreign body, those bacteria can travel up to the brain and I can end up giving meningitis to my patient. Okay, so whenever I have a fracture base of the skull, whenever I have any kind of communication between the cranial cavity and the nasal cavity, I will avoid putting a nasotracheal tube. Alright? Okay. An IV line has to be inserted in a child's hand. The mother applies Emla cream 45 minutes before bringing him to the hospital. Emla cream is a mixture of 2.5% lidocaine, 2.5% procaine, 2.5% lidocaine and prilocaine, lidocaine and procaine, lidocaine and prilocaine. So what is Emla cream a mixture of? Alright, first of all, what is Emla cream used for? So remember, whenever you want to give topical anesthesia, okay, what is topical anesthesia? If you want to reduce the sensations over a small area of the skin. So suppose I have a small wart over here, I want it cauterized and removed, or suppose I want to put an IV line. The most common thing to put is IV line. Okay, so at that time what happens is I basically put this Emla cream on, especially in children. I have to put it almost 45 minutes prior to taking the IV line. It takes a long time, it gets absorbed into the skin and you have to put the IV line. Alright, so what I do in this case is that I put this Emla cream and I allow it to act, and once it acts, after 45 minutes I take the IV line, so the child will not feel any pain. Okay, now what is this Emla cream made up of? Full form of this Emla cream is nothing but eutectic mixture of local anesthetic. It's like a creamy substance, eutectic mixture of local anesthetic, and it is made up of 2.5% lidocaine and 2.5% prilocaine. Okay, now can anyone tell me, if it contains prilocaine, in which hemoglobin condition will I avoid this? In which hemoglobin condition will I avoid this? Any idea? Any idea in which hemoglobin condition? Okay, so remember, in case of methemoglobinemia, I will avoid prilocaine. There are two things that I should avoid. One is prilocaine and one is benzocaine. Okay, so these are the two Local anesthetics that should be avoided in case of methemoglobinemia. Alright, so you should know EMLA cream very well. This has been asked many times in the exam before. Alright, a state in which the person is conscious, that is eye opening, swallowing, muscle contracture is present, but he is unable to process or respond to sensory input, is seen with which agent? Ketamine, propofol, etomidate or thiopentone? What is the name of this state and with which agent do you see this? What do you think is the name of the state? A state in which the patient is conscious, there is eye opening, swallowing, muscle contracture, but he is unable to respond. Yes, very good, Trilok. The correct answer is ketamine. But can you tell me what is the name of the state? What are we describing over here? Correct, Atmesh? Okay, so we are describing a state of dissociative anesthesia. Okay, so the patient feels that he is dissociated from the rest of his body. So something is happening, there are some sensory inputs, but he is not able to respond to it. It's almost like a dream-like state, like how in your dreams you can see that things are happening, like the exam time is getting over, but you are unable to write and you're not able to finish your papers. You know, you sometimes get those kind of nightmares. So those are nothing but similar state of dissociative anesthesia. You're getting sensory input but you're unable to respond to it. Okay, so that is a type of dissociative anesthesia which we see with ketamine. Alright, other thing that we see with ketamine, remember, is hallucinations, especially visual and auditory hallucinations, and you also see nystagmus in the patient. So these things are very specific for ketamine. And also you get post-op delirium with ketamine, and this is also called as on awakening you get post-op delirium in the patient. Alright, next one. In a circle system, most commonly used carbon dioxide absorbent is AMSOP, soda lime or baralime. This is the easiest question in today's class. All of you all should know the name for it. Circle system is closed system. Okay, Hriday is saying soda lime. Any other answers? And PK Manoj. Alright, everyone is answering it correctly. So it is soda lime. Okay, now this circle system is a closed system. All of you all agree to it. Open system of anesthesia is that Schimmelbusch mask that we have. What is the semi-closed system of anesthetic circuits? What is the name of the semi-closed system of anesthetic circuits? And do we use soda lime or carbon dioxide absorbent in semi-closed systems or not? Anyone? Alright, so semi-closed system is nothing but the Mapleson system, and in Mapleson system, remember, we do not use carbon dioxide absorbent. Okay, so CO2 absorbent is absent in this, and that's why you cannot recycle the gases. That is why it went out of vogue or out of use, because there was no recycling of the gases. So you were ending up causing a lot of pollution and wasting a lot of money. Okay, now when we talk about carbon dioxide absorbent, any of these, AMSOP, soda lime, baralime, any of these, what is the main component of the carbon dioxide absorbent? 90% of it is made up of what chemical? That is what they ask in the exam. Everyone knows soda lime is used most commonly, but what is the main component of soda lime? Most of you all end up answering it wrong. That's why I'm asking you this. Anyone? What is the main component of soda lime? Okay, so the main component of soda lime is actually calcium hydroxide. Okay, in fact, even AMSOPs and Bara lime, main component is calcium hydroxide. Along with calcium hydroxide, if I add sodium hydroxide, then the carbon dioxide absorbent becomes soda lime. If I add barium hydroxide, then the carbon dioxide component becomes Bara lime. If I add calcium chloride, I've written calcium carbonate, then my carbon dioxide absorbent becomes AMSOP. Okay, so that is how we have formation of the carbon dioxide absorbents. But always remember, the main component of all carbon dioxide absorbers is calcium hydroxide. Okay, alright. Malampatti score is used in pre-anesthesia airway examination. All of the following statements is true about Malampatti score, except it is used to assess oral cavity before intubation. In class 2, tonsillar pillars cannot be visualized. Higher scores are associated with higher risk of sleep apnea. In class 3, only hard palate is visible. Which of these are true except? So that means which is the false statement? Okay. So most of you have answered this incorrectly. The correct answer over here is D. Alright. So let's have a look at the Malampatti score. So it is used to assess oral cavity before intubation. That is absolutely true. Okay. In class 2, tonsillar pillars cannot be visualized. Okay, so in class 2 you will be able to see the soft palate, hard palate and the tonsillar pillars. Okay, so it is visualized, that is also true. Higher scores are associated with higher risk of sleep apnea, that is also absolutely correct. The more you go towards your Malampatti class 4, the fatter the patient is, the more obese the patient is. As a result of this, more chances of OSA. In class 3, only hard palate is visible. This is false. Okay. So, in class 3, you can see hard palate plus soft palate. And in class 4, only hard palate is visible. Alright. So, that is how you remember your Malampatti scoring. Okay. Alright. Next one. A residual neuromuscular blockade is being checked at the end of surgery using a peripheral nerve stimulator. Which of the following nerves is popularly used in clinical anesthesia to monitor neuromuscular blockade? Ulnar, median, radial or mandibular nerve? Yes, Manoj, the tonsillar pillars are seen in two. You can see the hard palate, soft palate. You can see the base of the uvula, not the tip of the uvula. The tip of the uvula gets obscured and you can see a little bit of the tonsillar pillars. Okay, so here what are we checking? We are checking residual neuromuscular blockade. So you are going to use a peripheral nerve stimulator for it. So basically you want to see whether the patient is out of the action of neuromuscular blocking agent or not. Okay, so which nerve can you stimulate for it? Now this is the one that everyone gets confused about. Whenever I mention about invasive arterial monitoring and I mention about neuromuscular blockade, there is always a confusion between the two. Okay, so remember, for invasive arterial monitoring, the monitor that you should be, the artery that you should be focusing on for invasive arterial monitoring is your radial artery. Okay, and when I talk about for checking of your neuromuscular blockade, what will you check in this case? Neuromuscular blockade, what will you check? You will check the ulnar nerve. Okay, so when you stimulate the ulnar nerve, what happens? Whenever you stimulate the ulnar nerve, you get movement of your adductor pollicis muscle. Okay, so adductor pollicis muscle is the one that moves the thumb inside like this. Okay, so I stimulate, I give electrical stimulus over here, and the adductor pollicis muscle will move inside. So as a result of this, what will happen when the adductor pollicis muscle moves inside, you will be able to stimulate your ulnar nerve, and you can say that the action of muscle relaxant is over. Okay, so that is your neuromuscular blockade check. Okay, we'll come back to it, Trilok. We'll just finish off the next few questions and then we'll come back to it. Alright? Okay, a patient is in the ICU requiring long-term ventilation. In an intubated patient, tracheostomy is performed when the duration of intubation exceeds 2 hours, 2 days, 2 weeks or 2 months. Okay, absolutely correct. Okay, so whenever we have a patient who is going to be intubated for more than 2 weeks, you will consider doing a tracheostomy. Now, if they ask you in the exam, why would you prefer tracheostomy in a patient for prolonged intubation? In a patient who is going to be ventilated, intubated for a long period of time, why do you prefer tracheostomy? Can you tell me what is the complication that can occur if you keep the patient intubated for a long period of time? One is ventilator associated pneumonia, but that can happen with tracheostomy also. Remember, just prolonged ventilation can cause both of them. But what is the specific complication that I will see with a tube? Any idea? I'll draw it for you guys over here. No, not infection. Infection can occur with tracheostomy also. Imagine these are your vocal cords and this is the area below your vocal cords. This is your subglottic area and here your tube is there and the tube's cuff is inflated for a long period of time. Now, at least now you all can tell me, yes Hriday, the words that you are mentioning are somewhat correct. Traction damage, but what is it? What can it cause? No aspiration, no akanksha. Okay, so what you can get because of long-term intubation is something called as subglottic stenosis. Okay, so because the cuff is inflated for a long period of time, this cuff will put pressure on the subglottic area and that will cause ischemia of the subglottic area and there will be finally over a period of time there will be stenosis of this area. Okay, so as a result of this, to prevent this, what we do is we put a tracheostomy tube. Okay, the second important thing with prolonged intubation is that a tube is not as secure as tracheostomy. An endotracheal tube is not as secure as tracheostomy. It can easily get displaced, it can get blocked. If the tube gets blocked, the patient will not get ventilated. All those things can happen. But the one that we are bothered about is subglottic stenosis. Your tube displacement, tube blockage, all of those can be prevented with good nursing care, but this cannot be prevented with anything. Okay, so long term intubation can lead to subglottic stenosis. That's why we converted to tracheostomy tube. So with this we complete the case based scenarios and now we will be moving towards just picture and diagnosis. Okay, and all of these are surgical images that I want you guys to diagnose for me. So there is this patient who comes to me with halitosis and cough whenever he is eating, and he is complaining of dysphagia. Identify the condition in this patient. Tell me the best investigation that can be done to identify this condition and what is the treatment. Yes, very good. So this is nothing but Zenker's diverticulum. Okay, so you can see this is Zenker's diverticulum. I think it became very easy because there was a arrow marked over there, but remember exam में there will be no arrows, there will only be one exit arrow कि तुम्हारा exam हो गया तो बाहर जा सकते हो. Okay, what is the investigation of choice? Investigation of choice and treatment. And treatment means I want to know the name of the surgery. Surgery is treatment of choice. What is the name of the surgery? Okay, investigation of choice will be barium swallow, absolutely correct. What will be the name of the surgery that we do? Yes, so absolutely correct, Akanksha. So it will be endoscopic Dolman's procedure. Okay, endoscopic Dolman's procedure. So what do we do? First of all, the Zenker's diverticulum is because of the outpouching through the cricopharyngeus and thyropharyngeus fibers in your inferior constrictor muscle, correct? Inferior constrictor muscle. This is also one of the questions that comes in the exam. So you have to cut through this pouch and you have to make sure that the entire esophagus becomes one single lumen again. Okay, so there is no food that is getting accumulated in the pouch. So for that we will do the endoscopic Dolman's procedure. Alright, okay, so that is about Zenker's diverticulum. Now this is a picture of the Zenker's diverticulum and how it occurs from the fibers of the cricopharyngeus muscle. Alright, identify the condition in this patient. He comes to me with dysphagia to solids and liquids and he is having weight loss. He has lost 20% of his weight in the past 3 months. So what is the diagnosis and what is the treatment? Give me the names of the surgeries. I just want to revise the names of the surgeries with you guys. Yes, very good. So yesterday only we discussed this. What appearance is this? This is like apple has been eaten into. Okay, so this is my apple core appearance. And apple core appearance is seen in case of CA esophagus. Alright, so can you tell me what is the investigation and what is the treatment? Investigation, of course, the investigation of choice, if you ask me, will be endoscopic biopsy, because you need to take a biopsy, you need to confirm that it is actually malignancy, and you also need to see whether it is squamous cell carcinoma or adenocarcinoma. Okay, what will be your treatment? Remember, barium swallow will not be the investigation of choice. Barium swallow will help you diagnose, but investigation of choice is endoscopy and biopsy. What will be the treatment for this case? No, Hriday, this is not achalasia cardia. Achalasia cardia, you will have bird beak appearance. Yes, very good. So treatment, I wanted to know the names of the surgeries. Absolutely correctly mentioned. So you have Oringer surgery, you have Ivor-Lewis operation, and you have McKeown surgery. Okay, these are the 3 names that you need to remember with regards to CA esophagus. Alright, okay. So this is just a picture that I have put for you all for your reference of endoscopic ultrasound. This is one of the investigations that we are using nowadays just to diagnose any kind of tumor or any obstructive lesion that is there in the esophagus. Okay, so this is how the picture of endoscopic ultrasound will look like. Can you see the esophagus is over here and you can see the aortic arch over here and the mass that is coming. Okay, and this is how the endoscopic ultrasound looks like. So these are the new investigations that nowadays they are using, so you should have a little bit of an idea of how it looks. Similarly, you should also know how the TEE probe looks like, the transesophageal echo probe. Now I have not put a picture of it, but you can go on Google and you can check TEE probe and how does it look like. Okay, so those are the kind of questions that will help you gain an edge over the others. Okay, so what is the part of the bowel that is highlighted in the picture here? And why do you say so? What is the part of the bowel highlighted in the picture here and why do you say so? Chalo, fatafat, fatafat. Pill camera. You can go and check all those on Google. Is this large bowel or small bowel? Megha is saying large bowel. Okay, so actually it is the small bowel. Remember, whenever you have the bowel centrally located dilated bowel loops, you will always have small bowel, and whenever you have peripherally located bowel loops, it will always be the small bowel. Okay, so here there are 2 things which are very, very characteristic. One is it is centrally located. Second is you can see the presence of valvulae conniventis. Okay, and these valvulae conniventis are seen in which condition? These valvulae conniventis are seen in the jejunum. Okay, Now tell me, is this large bowel or small bowel obstruction? Look at the air fluid levels, the location, and how does it look like, and tell me whether this is small bowel or large bowel obstruction. Sorry. I think the streaming has become a little slow. Okay, yes. So what am I having over here? I am having the air fluid levels in the center. Okay, and where are my dilated bowel loops? My dilated bowel loops are also in the center. Also, if you look at the dilated bowel loops, okay, so in the small bowel obstruction, your dilated bowel loops, the wall thickness, not wall thickness, like the diameter will not be that much as compared to a large bowel obstruction. I forgot what are the exact specifications. If any of you all remember, I think 5 mm, it will be more than 5 mm in small bowel obstruction and more than 20 mm in large bowel obstruction, something like that. Okay, I'll revise that and get back to you. But remember, if it is centrally located, then it is small bowel obstruction. If it is peripherally located, then it is large bowel obstruction. Abhi ye batao, is this small bowel or large bowel obstruction? Yes, step ladder pattern is also seen, correct. Chalo, the faster you will answer the images, the more images will be able to cover quickly. What is this, large or small bowel obstruction? Okay, so look at the multiple air fluid levels and see the arrangement of the air fluid levels, and look at the diameter of the bowel also. So even though it looks like there is some dilated air fluid levels in the center, but it's actually mostly in the periphery. Okay, so this is nothing but large bowel obstruction. This is large bowel obstruction. Okay, all right. Now identify the name of this sign without trying to look for it in the picture that I have put. Identify the name of the sign and identify the condition. I'm sorry, I think the streaming is happening a little slowly, and that's why it's taking time for you all to get the question and then for me to get the answer. Anyone? Okay, so the name of this sign is string of pearl sign, and in which condition do we see the string of pearl sign? Again, in case of small bowel obstruction, we see the string of pearl sign. Okay, so this is the string of pearl sign. You can see the air fluid levels are arranged like pearls. The another cause for string of pearl sign or chain of lake appearance is in case of pancreatic stones. Okay, so you can have both of them, but here you can see that the air fluid levels are present in the center like that of a dilated bowel loop, and that is why this is called as string of pearl sign seen in small bowel obstruction. Okay, all right. Ye batao, last one, small bowel or large bowel obstruction, and then we'll move on to the next type of pictures. So you can see the air fluid levels, and the dilate. Can you see how dilated the bowel loop is? So in large bowel obstruction, always the bowel loops will be very much dilated as compared to the small bowel obstruction. Yes, so this is nothing but large bowel obstruction. Barabar. Okay, moving on to our next picture. What will be your next step in this case? Will you pass a flatus tube? Will you do a CT scan? So I'll give you 4 options. Will you pass a flatus tube? Will you do a CT scan? Will you put a Ryle's tube? Or will you take this patient for emergency laparotomy? What will be your answer for this? Okay, Trilok is saying he'll pass a flatus tube. Atmesh and Hriday are saying D, emergency laparotomy. Okay, so everyone knows that this is nothing but a sigmoid volvulus. Correct? In a sigmoid volvulus, there is twisting around the axis of the colon. So as a result of this, you are not going to be able to release any of this air because already the bowel has twisted around its axis. If you wait for a long period of time, it is going to lead to ischemia of the bowel wall. Okay, so you need to untwist the bowel and milk the air that is collected inside it. So for that you need to do a laparotomy. So you need to do an emergency laparotomy. You don't need to go for any other investigation because it's very obviously seen over here. So you untwist the bowel, you do a laparotomy, untwist the bowel, milk all the air that is collected inside the bowel wall, and then you do a sigmoidopexy. Okay, sigmoidopexy is nothing but you hitch up the bowel, or you make sure that the bowel is attached to the abdominal wall so that it does not twist again, because this can occur again and again, volvulus. Okay, so you want to avoid that from happening. Alright, next picture. What is the name of this sign and in which condition do we see it? Yes, very good, Manoj. This is continuous diaphragm sign. So you can see the right hemidiaphragm and the left hemidiaphragm, and actually you can see the entire part of the diaphragm is continuous. You can see that there is some amount of air that is present between the base of the heart and the diaphragm. So what is this condition? Perforation. Are you sure? There is collection of air between the base of the heart and the diaphragm, correct? So what is this air called as? This is called as pneumomediastinum. Okay, so there is free air that is present in the mediastinal cavity, so this is called as pneumomediastinum. Okay, so pneumomediastinum, you see continuous diaphragm sign. Alright, it's also similar. What is the name of this sign and this is seen in which condition? Yes, very good. So you can see the thymus is lifted up, and this is called, and it looks like the sail of a boat. Remember when we were kids we used to make that boat? So this is the sail of the boat. So this is called as spinnaker sail sign. Okay, and this is seen in which condition? Spinnaker sail sign is seen in which condition? Anyone? Any idea? Batao jaldi. Yes, your spinnaker sail sign is also seen in case of pneumomediastinum. Okay, alright, moving on to our next condition. what is the name of this sign seen and in which condition do you see it? So all of us will agree that this is a barium swallow. What is the appearance that we see in this barium swallow? The appearance is called as a shaggy esophagus. In which condition do we see shaggy esophagus? Anyone? Yes, very good. It is seen in esophageal candidiasis. This is seen in esophageal candidiasis, shaggy esophagus. Okay. Alright, this is commonly the background that they will give you is there is an HIV positive patient and he is having dysphagia to solids and liquids, and you do a barium swallow and this is what you see. Because he is immunocompromised, he is prone to getting candidiasis of the esophagus. Okay, treatment will be antifungals. Okay, again, what is this appearance called as and what is the diagnosis? Yes, very good. This is called as moth-eaten esophagus. And in which condition do we see this moth-eaten esophagus? Again, this is a barium swallow only. Not CMV esophagitis. So the filling defects that you see over here is because of dilated esophageal veins. Okay, so this is because of dilated esophageal varices that you are seeing the multiple filling defects in. So this is seen in case of esophageal varices. Okay. Alright. Okay. Identify this condition and tell me what is. Okay. Once you will identify the condition, then I will ask you the next question. Or composition. Give me that composition. Composition of what that you will need to diagnose. Yes, very good, Manoj. So this is nothing but staghorn calculus. It's taking the entire place of the renal pelvis. Correct. So this is nothing but our staghorn calculus. And this staghorn calculus that we have is mostly composed of what? Very good. So it is mostly made up of struvite or triple phosphate. Okay. Identify the condition. This is a fat fertile female of 40. She is coming to me with abdominal pain in the right hypochondrium after meals and a lot of belching after meals. Yes, very good. So what can you see over here? You can see cholelithiasis. Okay, so the gallbladder, the liver will be over here, the gallbladder will be underneath it, and you can see presence of gallstones. Okay, so this is nothing but gallstones that are present. This patient will have to undergo a cholecystectomy because she is symptomatic for the same. Okay. This patient is coming to me, he is a chronic alcoholic and he is coming to me with abdominal pain radiating to back. Itna de diya na, you can easily identify the organ that we are talking about and then you can tell me the answer. That's what you just need to know. Abdominal pain radiating to back, it's more than obvious that we are talking about the pancreas over here. Okay, so directly in the picture, look at the pancreas. What can you see over here in the pancreas? You can see there are presence of multiple calculi. So this patient is suffering from pancreatic stones. Okay, like that only. The previous one also, I told you fat fertile female of 40 having pain in right hypochondrium. Directly you should be looking at the right hypochondrial area. Directly you should be looking at the gallbladder area. If I tell you some patient is there with menorrhagia and she is having pain in lower abdomen, directly you should try to look at the area of the uterus. Okay. Okay. Quickly, what is the name of this sign? Now the next 10 will be very quick. 10 pictures in hopefully 20 seconds, because it takes an extra 10 seconds to just stream it for you guys. Yeah, so this is called as Pemberton sign. Okay, Pemberton sign seen in which condition? It is seen in case of retrosternal goiter. Okay. Identify the condition. Psammoma bodies and orphan annii nuclei. Both of them will join together and will give us papillary CA thyroid. Okay. Chronic tobacco chewer, his mouth opening has become F. From A it has become F. Chronic tobacco chewer. What is he suffering from? This is submucous fibrosis. Alright. Next. This patient is presenting to me with dysphagia and presence of this. This is what you see on endoscopy. And she is also having iron deficiency anemia. Yes, so this is Patterson-Brown-Kelly syndrome, or this is also called as, what is the other name? It is also called as Plummer-Vinson syndrome. Okay, so the picture that I have given you over here is nothing but of a esophageal web. Esophageal web that is causing the dysphagia. Okay. Identify the cancer in part A, picture A. Identify the cancer in picture B. And tell me which is more common in India. चलो guys, जल्दी जल्दी जल्दी. Okay, so on the lateral border of the tongue, you can see the tumor. This is CA tongue, and here you can see the tumor on the inner part of the buccal mucosa. So this is CA buccal mucosa, which is more common in India. Remember, in India we have chronic tobacco chewers. तंबाकू खाने वाले लोग बहुत होते हैं. So they keep the tobacco on the side of their mouth for a long period of time, which causes chronic irritation and can lead to cancer. So CA buccal mucosa is more common in India than CA tongue. Okay. Alright. Identify this flap and for which surgery is it taken, for which cancer is it taken. Identify this flap and for which cancer is it taken. Okay, so this is what muscle? The muscle that we are taking over here is your pectoralis major muscle. Okay, so this is called as pectoralis major myocutaneous flap. Pectoralis major myocutaneous flap or PMMC flap. Okay, so this is PMMC flap, which is used for reconstruction of any kind of oral cavity cancer. Okay, then here we have the flap which is taken from this area, from the deltoid as well as the pectoral. This is also taken for oral cavity cancers. This is called as the deltopectoral flap. Okay, next you are getting two flaps. One is taken from behind. So this is your latissimus dorsi flap, and one is taken from the front. This is your tram flap. Tram, transversus abdominis muscle flap. Okay, so both of these flaps are taken for reconstruction in CA breast. LD and tram. More commonly LD flap is taken. Okay. Okay, identify this condition. Give me the treatment. Fluctuant swelling, transillumination test positive, arising from the sublingual glands. Yes, so this is called as a ranula. And what is the treatment of a ranula? It is nothing but marsupialization of the cyst. Marsupialization of the cyst. Okay. Alright. So there is a swelling over here. It pushes the ear up. Swelling pushing the ear up. This is a parotid swelling. If the ear is getting pushed up, that means it is a parotid swelling. Just remember that. Okay. Alright. Identify both of these instruments used for taking biopsy. What is A and what is B? Most common parotid tumor that we see is pleomorphic adenoma. Okay. Okay, so A is nothing but a punch biopsy needle and B is a true cut biopsy needle. In which condition do you take punch biopsy? In which condition do you take true cut biopsy? Okay, so if you want to take biopsy from your skin, we use a punch biopsy needle. If you want to take biopsy from your prostate or breast, we use the true cut biopsy needle. Okay, alright. Retraction of the nipple. What is the causative condition? Condition that causes retraction of nipple? So I'll show you all the images. Tell me the reasons for it. First one is, what is the cause of retraction of the nipple? What is the cause of further orange appearance of the breast? And what is the cause of popcorn calcification in the breast? This is on mammogram. Chalo, these three answers, tell me quickly. What is the reason for retraction of nipple? What is the reason for further orange appearance? And what is popcorn calcification of breast? Okay, so a further orange, at least all of you all know that the lactiferous ducts that are there, they get clogged by the cancer cells. Okay, So as a result of it, you are getting the orange appearance, correct? Yes. Popcorn calcification of breast is seen in case of fibroadenoma. Okay, and why do we get retraction of the nipple? Because of involvement of the Cooper's ligaments. Okay, if the cancer involves the Cooper's ligaments will get fibrosed and you will have retraction of the nipple. Alright. Okay, now this mammogram, can you identify the condition for me? You have multicentric distribution of the tumor. So this is a typical example of CA breast, typical mammogram of CA breast. Alright. Okay, this is a young mother. She is a 21-year-old female and she is presenting to you with a swelling in along with fever. Any idea what is this? Swelling along with fever. So this is nothing but a breast abscess. Okay, so mother who is breastfeeding, new mother, she can develop a breast abscess. Most common organism is Staph aureus. Okay, alright. This is a 55-year-old female coming with this large leaf-like swelling of the breast. So what is this? This is nothing but cystosarcoma phylloides. What is the treatment for this? You have to do a simple mastectomy. Okay, cystosarcoma phylloides. Okay, this one, dilatation of the veins below the breast. This is called as Mondor's disease. Mondor's disease, this is nothing but superficial thrombophlebitis. And what is the vein? So basically inflammation of the vein, correct? And what is the vein that is getting involved? It is nothing but lateral thoracic vein. Superficial thrombophlebitis. Okay, this bilateral enlargement of male breast seen in gynecomastia. Anyone, what is this swelling seen in a child? Child is born with this swelling. It is due to abnormal lymphatic cysts that are getting sequestered and not joining the main lymphatic duct. This is called as a cystic hygroma. I am actually telling you all the answers quickly because it's taking so much time to stream. That's why. Okay. So this is diabetic patient. He is coming to me with the skin that is macerated behind and he is having this condition. So what is this? The name of this condition? In diabetic patients, at the nape of the neck, very specific area, infected macerated lesion. Chalo, ये तुम लोग बताओ. Meanwhile, I'll tell you the next one. This is the WHO surgical safety checklist. This you should know. It's very, very important. It has 3 parts. At sign in, when your patient is being taken in for surgery, just before the incision is to be taken, and just before the patient is being taken out of the operation theatre. So once the patient is taken in the operation theatre, once the patient is taken out of the operation theatre, and this is right before the incision. 3 parts of the surgical safety checklist. Yes, absolutely correct. This previous one was nothing but carbuncle. Okay, now all the positions, all of you all know the positions. I am quickly just telling you. Supine, when the head is down, it is called as Trendelenburg. When the head is up, then it is called as reverse Trendelenburg. बहुत बार आता है ये एग्जाम में, that's why I'm just revising with you all quickly. Then this is lithotomy position. This is lateral position. Right side is down, so this is right lateral position. This is right lateral position with a break. This is called as kidney position. Then H is nothing but your prone position, and this is called as your beak chair position or your Fowler's position. Okay. Then here you have a picture of the urine bag. You should be able to identify these two. SSSA markings है, slanting markings. So this is your urine bag, or it is also called as the urometer, to calculate the amount of urine, or rather measure the amount of urine that comes. And this one, in which the tubing is going right till the bottom, and you will fill the water over here. This gives you a underwater seal. This is nothing but your intercostal drain bag. Okay, intercostal drain bag. and it won't have these slanting markings, just remember that. Okay, this two pouches are there. One is your colostomy pouch, the one which opens like a pouch with a velcro over here. If it has a small tubing like this which connects to a Euro bag, then this is your urostomy pouch. Okay, and the last picture for today, you have your staplers. So this is your linear cutter stapler, mainly used for cutting and stapling all your your stomach and your intestines. And this one is used for hemorrhoidectomy. This is called as the circular stapler. Okay, so these are all the pictures that you need to revise for your exam, and I hope that this class was useful to you guys. Please don't forget to leave a thumbs up at the end of the class. Please don't forget to be a part of this channel, Let's Crack NEET PG Telegram channel. So here I'll be posting the links to all my classes. Tomorrow I'm going to do a mega revision of anesthesia for those appearing for NEET PG. So this will be on YouTube only. One session will be at 4 o'clock in the evening, one session will be at 6 o'clock in the evening. In 2 sessions we are going to complete the mega revision of anesthesia. So I hope to see all of you guys for those sessions. Until then, keep studying. See you. Bye bye.